Welcome to Webinar Wednesday, everyone. Thanks for joining us. I'm Carly Andres. I'm the Outreach Coordinator for the North Dakota Brain Injury Network. We host these meetings every other Wednesday from 1:30 to 3. You probably have seen our current flyer, so we do have a few more lined up. In 2 weeks, we are taking it off for NASHA, but following that, we do have several others scheduled. So join us, and if you would want to speak or know anyone that would be a good speaker or a topic that you'd want to hear, please feel free to email me. I can give you my information at the end of the presentation. But I want to welcome Tom Tatlock today. He is a TBI survivor. He sustained his injury in May of 1999, and since then he's become a volunteer educator on TBIs and an advocate for persons with brain injury. He said he invites himself to speak to groups that he thinks should know about TBI, even if they don't want to. So welcome, Tom. I'll share my screen here for you. And I will let you get started. It sounds like Tom would ask for questions at the end of his presentation. I just want to do presenter mode for you.
Can you make me disappear?
Oh, sorry. I just closed up. I'm going to have to open that again. There we go. You seeing my screen now?
Can you make me disappear?
I can't, Tom. Sorry. Do you want your video shut off? Would that help you?
That's fine.
Okay.
First, let me thank you all for letting me talk about traumatic brain injury in the persons who are homeless. This has been an area of interest to me for some time and has become really an area that I'm fairly passionate about. Can we look at the next screen?
Yes.
We have illustration of my technological incompetence. I had to send these to Carly in the sense I could never get mine loaded so I could advance them from here. This is basically what we're going to cover, some basic information on TBI and then the persons who are homeless, and then talk about the Appleton Project, which includes Brain Fox Valley and ultimately leads to a grant from the Community Foundation and the creation of a new organization called Traumatic Brain Injury Support Group. And then I hope to have questions and comments at the end. Next. Many of you already know that a traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. It can't be hereditary, congenital, caused by a birth trauma, or congenital degenerative induced by birth trauma, or hereditary. It's important to know that the brain doesn't have to be the skull doesn't have to be in contact with anything, and you don't have to have loss of consciousness to have a brain injury. The effects can be mild or severe, simply from being dazed to being in a coma and vegetative state. The consequences can be brief or lifelong. And next, this is the scope of the problem. This is the data from the CDC in 2014, and it says 2.87 million people sustained a brain injury, and 2,500 were seen in the emergency room or hospitalized. I didn't update this slide to the correct numbers, I guess. 56,000 related TBI deaths. And between 2006 and 2014, the number of persons who sustained a brain injury that we know about increased by 53%, from 1.88 million to 2.88 million. But that's really an underestimation, because these are people who are seen in the emergency room or in the hospital. There's a large number of people who may be seen in their doctor's office or someplace else or an even larger number who probably don't seek any treatment at all. It's called the silent epidemic. Next. Because it's invisible. And I must have just, anyway, these are not the updated numbers, so you can just use the others. But you'll notice that 10% is mild, 10% is moderate, and then of the 2 million, 75 to 85%, 300 to 500,000 are in a category called the miserable minority. There are people with mild traumatic brain injury who have ongoing and lifelong limitations. I'm a member of that club. It's not a club I would invite anybody else to join. And I think people frequently forget that traumatic brain injury is really a chronic disease. When people have symptoms that are persistent, can be a chronic lifelong disease. Then looking at the classification of severity, which is next. In mild, you don't have to have any loss of consciousness, and you can have it up to an hour. In post-traumatic amnesia, you can have from none to a day. Moderate is 1 hour to 1 day, and 1 day to 1 week for amnesia. And severe is greater than a day for loss of consciousness and greater than a week. There's also a Glasgow Coma scale that I'm not going to really spend much time talking about because it's really a medical evaluation that is rendered at the time the person is first seen. The scale is 0 to 15, 13 to 15 is mild, 8 to 12 is moderate, and below that is severe. Next slide is looking at populations that are particularly high risk. Veterans are a high risk population. It's important to know that maybe 80% of the veterans who have traumatic brain injury, they were not in combat. The homeless have between 30 and 50%, and we're going to focus on that. And people who are incarcerated have 27 to 85%. You all may have known these statistics, but for me, they were a real shock when I first learned them. And then men are about 1.5 times more likely to get traumatic brain injury than women. And the peak ages are 15 to 45 when people are more active, more likely to take risks. Below 5 years old, and now for those of us over 75, we're also at high risk again. And that's primarily from falls, which makes falls now the leading cause of traumatic brain injury. And next. These are the areas of the brain, and each one has its own special function. And we're going to focus primarily on the frontal lobe and the temporal lobe. And those are the parts of the brain that are most injured in traumatic brain injury. If you think of the brain as kind of partially formed jello that floats in the cerebral spinal fluid inside our skull is a protection of the brain, but it also can cause damage to the brain. And the next slide shows the interior of the skull. It has these bony ridges, and what happens is the brain and the skull move at different rates. So the frontal lobes and temporal lobes go over. I can't draw with my hands because that can lead to contusions and bleeding and loss of function. There also is a problem called diffuse axonal injury that happens, but we're going to focus primarily on this part of the brain. And the next slide shows what happens in whiplash. And it gives kind of a picture of what it's like for the brain moving back and forward. I think of it kind of like when you might have been a child and playing with a paddle ball, and you bounce the little ball off the paddle, it comes back and forth. And that's what causes most of the frontal and temporal lobe damage. No matter where your brain injury is, as long as it's not like a penetrating wound or something like that, it's almost always the damage is in the frontal and temporal lobes. And that's because of the structure of the skull and where the brain moves over that. Next slide. As I said already, there's preferential damage for the frontal and temporal lobes of the brain. And the next slide talks about what are the frontal lobe functions. And these are really the functions we need to function or need to have to be able to use to function in society today, to be able to plan, anticipate, solve problems, have mental flexibility. And those are frequently disrupted. And as you can see, they're not going to cause external signs. Some people have expected, you will see physical signs from a brain injury and confuse that with something like stroke. Most brain injuries are invisible. And the next slide talks about what goes on with the temporal lobe. And it's important to know, and I'll probably say that later, that the memory that you have and the learning you have before the injury stays intact. It's the new learning that becomes progressively difficult, sometimes impossible. It sometimes fools people into thinking that the person is functioning at a higher level. It can be particularly confusing in school-age children where it looks like they are really functioning, but they're learning, they're drawing on what they've learned in the past. And the next slide. So here are some relevant problems. And I didn't list all the problems. I listed some that happened to me. And the cognitive functions, and we'll talk about impaired executive function next, but learning new information and physical pain can be headaches. Seizures are much more common. For me, at least, when I'm tired and fatigued, I can lose my balance, physical balance as well as emotional balance. And this invisible sensitivity to external stimuli, sound, light. And I think one of the biggest problems that is sometimes unrecognized is the amount of fatigue that comes with traumatic brain injury. I think of it as related to an invisible thing. It's like you're bicycling into the wind and you're riding along with a whole group of people who are bicycling, and none of them are having to pedal into the wind. You're having to spend a lot of energy to just organize your brain to filter out external stimuli, to do things that we do automatically without thinking. And that has been a major problem for me and continues to be. And the other thing that frequently happens is these functions lead to change in personality, which then leads to change in social relationships, which can lead to isolation, can lead to depression, can lead to marital difficulties, job loss. And then the significant losses. The difference with brain injury versus a kind of developmental disorder or a disorder from birth is you have function at a certain level and all of a sudden you can no longer function at that. And for me, and I think for many, many people, that loss of your identity, that loss of ability to be who you were is a major problem. One of the major tasks is to not compare yourself to who you used to be. I draw a kind of picture where it's like a graph, and here's where you were, and then you have your brain injury, you come down, and you need to look from where you were at your worst with your brain injury to see that you've improved. Because if you measure yourself just against your old self, you will always feel kind of like a failure, or I'm not measuring up, or I should be able to do those things. Knowing that intellectually does not get rid of the difficulty of having to live with that. I still remind myself to look where I started, not where I used to be. Then we're going to look at the executive functions on the next slide. And these again are the higher level functions. How do we initiate things? How do we start things? And not only initiate things, but how are we able to stop? Because I think of it as kind of like getting stuck. And you can see how impairment of these functions predispose you to other problems. Being impulsive may lead to social problems, may also lead to drug use, may lead to risky behavior that causes you to have another brain injury. This concept of planning and organizing, if you looked at my study, you would see something that my wife frequently has to bring in a front loader and reorganize. I was not the greatest organizer before my brain injury, but now it's kind of like the old cartoon character Pigpen. I just have clutter that grows exponentially, and that makes it harder to do everything. I've learned to use a planner in a daytimer kind of way to organize myself and to try and figure out what I want to do and how I want to go about it. And then in the planning process, to be realistic about what are the limits of my cognitive energy? What am I able to accomplish? And then what is most important? What do I want to do? Mental flexibility is how do we have a plan B, C, and D? I'm going to talk about mental flexibility, at least as related to me as far as fatigue. When I get too tired, I do click back to being on automatic pilot. I do what I used to do. Before I knew much about brain injury, I thought, all my life, I'd gone to medical school, internship, residency, been in private practice as a psychiatrist. When you had a problem, if you worked harder, things got better. Well, I learned finally that that was exactly the wrong thing to do. But when I pass this kind of window of awareness, I go on to this automatic pilot. And I call that the Wiley Coyote syndrome. It's like Wiley Coyote gets farther and farther over the edge of the canyon and then comes crashing down. And that leads to significant fatigue. And at least for me, the fatigue is such that it's much easier to get too tired than it is to recover for that. And the way I think about that is you've overdrawn your emotional and cognitive energy bank account. And for me, if I get too tired, it takes me not the same amount of time to return to the previous level of functioning, but takes me 2 or 3 days or more. It's kind of like you've taken a loan out and all of a sudden you're having to pay the loan off at payday or credit card interest rates. When I'm talking about the planning and organizing, if I can go into something like this kind of presentation without my account overdrawn so I can rest up, it's not like I can accumulate extra cognitive and energy, but I can go in with not a deficit. Self-awareness, I think, is important, and that is something that the person with a brain injury frequently has some impediment. I know that my wife will tell me sometimes, I think you're really tired. You should go take a rest period. And I can tell you she's usually right, but I can also tell you the recipient of good advice is not always grateful. There are times when you just wish that that wasn't said. But I'm going to give you an example of lack of self-awareness. People had had us over for dinner when the first couple of years, and they would prepare an appetizer, main course, side dishes, dessert. And so we tried to have some people over for dinner. I thought I would do the same kind of thing. Well, on 2 occasions, my mental flexibility and my declined enough that I in my fingers. I learned from that. I prepared simpler dinners. I also took a knife skills class, but I think the knife skills class was not as helpful as increased self-awareness. And it's in a way depressing to know what your limits are, but if I tried to be the person I used to be, I can't function nearly as well as I can if I get in what I think of as my circle of competence. If I get in that circle of competence, I can push the boundaries and I can get better. Otherwise, if I'm just doing as much as I can, I'm in this kind of boom and bust cycle. I do well, and then I come crashing down, and I think, oh, well, I really feel good today. I'll accomplish all these things. Who knows when I'll feel good again? So I do too much. I've gotten aware enough that I am able to kind of stop doing that, pretty much, at least. The next one is some examples from the past. I'm going to talk about, I've given you some information about the troubles I had with my own brain injury after I fell off the ladder and placed the back of my head on a concrete sidewalk. People told me that was a mild brain injury. I ended up coming in, wrapping my head in a towel after rinsing it off under the kitchen sink, and told my wife, let's go to Vermont. We were going to go to our son's graduation. She says, oh, let's go to the hospital. So we went to the hospital, and I was hospitalized overnight, and they did a CT scan, and one of the people read a subdural hematoma, small, and the other one read a subarachnoid bleed. And by the time they admitted me and I got up to the hospital room, I felt like kind of having a steel rod driven through my head, and probably the worst headache I've ever had in my life. I was just there overnight. They did a CT scan, and the next morning, and they said, well, you can go home. In fact, you can even fly to Vermont. Now, this was 20 years ago, and I was seen by a neurosurgeon, and I think the care may be different now, but anyway. So I went on to Vermont. But there was really no follow-up care. I saw the nurse clinician for the neurosurgeon, and she said to me, your mental status is normal, your neuro exam is normal, you should be back to yourself in 6 weeks. Well, I'm still not back to myself, but I was able to take a month off, which I think of as kind of a month of sleep and pain. And then I tried to return to work. And when I did, I could work for a while, partly because I could control the environment. I could see a patient, I could lay down and rest for maybe a half hour, an hour, see another patient, and see maybe a quarter of the amount of work I did before. But since I looked normal, people said, well, why don't you get back into the call schedule and take care of the people admitted to the hospital? I said, no, I can't do that, because I just knew that I would cause injury to the patients. Anyway, this was leading up to my getting interested in people who are homeless, partly because of the struggles I had. But, you know, Andrea and I were very fortunate and very grateful. We had unusual privileges with this kind of brain injury. We'd been married for 30 years. We had a stable marriage. I had stable housing. Our children were just graduating from college. We had twins. I had some economic resources and disability income. And even so, things were really difficult for me. And I began to think about people who had much more problems. So I'm going to give you a couple of examples of some people that I saw soon after, when I first started giving talks to homeless providers. And that was in 2008. And after a presentation that included a number of homeless providers from different organizations, a man from the Salvation Army came up and said, you know, I was listening to what you said, and I was wondering about one of our clients. He seems to do kind of what you do when you get overwhelmed by sensory stimuli. He seems to be more grumpy, harder to get along with, kind of much more irritable, short-tempered. And so we started talking about this individual. I said, well, where does he live in your facility? And he said, well, he lives right off the day room, right next to the elevator. I said, oh, what would you think about moving him down to the hall, the quiet end of the hall, and see how that goes? And then let me know. And about a week later, he called back and said, you know, this is a remarkable change. He's markedly better. And I guess I bring this point up because you'll hear it later on as well. A lot of interventions are not rocket science. It's just considering the possibility that the person might have a brain injury and thinking about, you know, what are the problems and what might be alternative solutions. The second example is A woman from a shelter came up and talked to me about one of their clients, and she said, this person is just driving us bonkers. We're about ready to discharge her. And I said, well, what's kind of going on? And she said, well, she won't do what she's assigned to do. She'll never vacuum the living room rug, even though we tell her again and again. We just see her as somebody who's lazy and irresponsible, and we're really thinking about discharging her. And I said, well, let's find out a little bit. Well, what kind of problems did she have before she ended up at your shelter? Well, she had problems paying her bills. She missed her rent. That's why she was evicted. She just wasn't very responsible there. She showed poor judgment. She didn't have as good a memory, and she didn't have very good control over her impulses, but she just was irresponsible. So I asked him about, well, where do you tell this person the tasks that she needs to do? He said, well, we tell her like we tell everybody else, in the hallway. I said, well, what is the hallway like? Well, there are lots of people passing by all the time. So we're telling her, and she just never seems to get it. Where she gets it and just never follows through. So I said, well, what do you think about trying to not tell her there, but talk to her in a quiet room, one-on-one, and maybe write down the instructions for her as well, or build a kind of way that you may overcome some of her problems with both memory and sensitivity to external stimuli. And once again, the person called me back and said, you don't believe what happened. This irresponsible, lazy person has turned into somebody really responsible and cooperative. She does what she's supposed to do. And I keep hearing these kind of stories again and again. And that's part of what's made me become really passionate about the topic of persons with homelessness who have suffered from a traumatic brain injury. The other thing that really makes me happy is I keep hearing from staff members, you know, we really have much more understanding. We've never thought of this person as having a problem. We just saw the surface problems. We just saw the behavior. And as we've made these modifications, not only do we have more understanding and empathy, but we also are much more effective. We implement some really simple strategies, and things really make a difference. And you'll hear more about that when I talk about the Appleton Project. But this is the kind of thing that's made me passionate about helping people realize about what traumatic brain injury might have as far as the effect on somebody who is homeless, somebody who's living in a precarious situation, moving from environment to environment, lack of stability, kind of fear of, you know, where am I going to eat next? In some cases, where am I going to sleep next, or how I'm going to provide for my children? It's kind of the exact opposite of the benefits that I had as far as stability. That's why I feel so grateful. And so now we're going to switch to talking about some of the people who have brain injuries and who are homeless. And one of the important things to figure out is, what does homelessness mean? And I'm not going to read this to you, but we're going to see on the next slide really a definition of homelessness. And the first one is likely for people with minimum wage jobs or transitory employment or family difficulties. And the transitional is the most common. That's usually just some kind of a catastrophe, and it's usually temporary. The hidden one is one where we just don't know how many people are there. Surveys try and measure that. Some of them do fairly good, but I think there's a much greater number of people who are, you know, sofa surfing and staying with friends and just a rotating environment. But once again, this is not stable, it's not consistent, it's not the kind of thing that most of us need as individuals. And somebody with a brain injury needs more of a kind of structure. And then the chronic, in the 1 year, at least in some definitions, is it doesn't have to be a continuous 1 year. It can be 1 year if there are 4 episodes in the, over 3 years that equal 1 year. But I guess as we think about this, imagining ourselves being in an environment like that, what it would be like if we had some cognitive impairment. The next slide, no, is there, oh, yeah. The arrows go both directions in this, and there really should be a box for major mental illness. And if you think about how TBI contributes to homelessness, before I started learning about this, I thought, oh, some of the statistics about homelessness, that would be a cause of people having TBI. It is, but it's not a primary cause. The arrow from TBI to homelessness is a bigger arrow than from homelessness to TBI. But I thought they live in a dangerous, unstable environment. Things are likely to happen as far as physical abuse. But this is a kind of circular thing, and I think it helps to think about what is the cause and what might we do farther upstream to take care of some of these problems. The next slide is this article by Stubbs came out in Lancet in January of this year, I think. And it's probably the definitive current article. It reviews 38 studies in a meta-analysis and 22 studies for, 22 for meta-analysis and 38 for overall. They basically got all the literature about TBI and homelessness that was in the English language, and they selected these as articles that are worth really valid research. I have to admit, I didn't understand any of the kind of stuff as far as the meta-analysis, but I just trusted that the editors of the magazine were able to understand that and that the studies were valid. But you can see the kind of numbers from the prevalence from all the studies is about 53%. But there are also about 22.5% that have severe TBI. There are not as many studies that break that out. And you'll hear this again and again, kind of the average age is 15. And TBI in general is 2.5 to 4 times the general population, but the severe is 10 times the general population. I'm always a little bit semi-skeptical because I think we don't really know what the prevalence is in the general population. Colorado has done some studies that has a higher number because they did phone calls and follow-up and things like that. The next slide. This, I think, is really important. Statistics are people with the tears wiped away. Because most of us deal with individuals. The statistics feel kind of impersonal. They can provide some kind of guidance for what we might be looking for. But I really think this is an important way to look at all the data that is there. You just kind of think of the number of people in these different studies and what that would mean for their lives and the lives of people who care about them and who are dependent on them. The next slide shows frequently how people are described when they're homeless with TBI. Unmotivated, well, we already saw the decreased ability to initiate. I think the worst label in my mind isn't on that list. The worst label is when you hear somebody say, unable to benefit from treatment. That's really where the lady who was giving the instruction in the hall was. And I think oftentimes we don't look for the possibility of a traumatic brain injury behind the more apparent mental illness or the more apparent substance abuse. There's a saying in medicine that I think is very true. You can't make a diagnosis you don't think of. So if you don't consider that TBI might be one of the problems behind that, you really won't ever be able to get that. Then we're going to look at the next slide. We're going to see quite a few studies here in a row and just how common is homelessness. Wang, who did a big study in Toronto, have found 50% What's interesting about the Wilder research is they're a research organization that does this kind of study. They do a study in Minnesota, but they do the whole state. They do a survey every 3 years. But it's really important because it's not just urban centers, it's rural populations as well. And it's worth going to their website and looking. They break things down by all kinds of different ways. They're talking about how particularly older people are becoming homeless in Minnesota at a much higher rate. But both of them agree to some extent that the TBI happens before the person becomes homeless, and it occurs at a younger age. And it's a mild TBI. And this is going to be important because I think the mild ones get missed so often. Medical professionals may not be attuned to it. The person who has their brain injury may not be aware of it. They may be kind of not so smart like I was. I said, let's just go on to Vermont. Everything will be okay. But I think it's under-recognized. Next slide will show a study from Boston. This was by Carol Waldman, and she was one of the persons who helped me when I first started talking about TBI. And what is striking is, to me, only 67% sustained an injury, but only less than a quarter of those people had any post-injury follow-up. And 44% were getting into other problems, drugs, alcohol. And we don't know from that particular study how many might have been using before, but you can see some of the kind of problems that happened: mental illness, cognitive problems, behavioral problems. This was an early study, but once again, it's from an urban center. I think that's most of what I had to say about that. And the next slide is another one from Toronto. And I want to talk a little bit about how the Toronto program research was set up, because I think it makes a difference when we look at these articles to figure out, how did they compose their, the folks they were working with. Toronto is a large Canadian city. They recruited 50 people from, recruited people from 50 different shelters, 18 different meal programs over 12 months in 2005. 10% were recruited from the meal programs. They had a ratio of 2 men to 1 woman. They did not include any homeless families. They initially screened about 1,680 individuals and found about 1,190 eligible. And about 70% of those people agreed to participate. And the participants got paid $15. And they asked the people, when we get into, well, I'll get into that in a minute. And they asked the people, it was a simple question about, had you had a TBI? It wasn't an OSU kind of screening test. But you can see how prevalent that was. Maybe you're not weren't initially surprised by this, but I was. The next one shows 70% before they became homeless, 7% in the same year, 2% they didn't know, and 22% after they become homeless. The next slide is a graph, and this is helpful to me to just see how long ahead of time people might have had their brain injury before they become homeless. There's an interesting article by Burton written as an interview with Wayne Gordon. It talks about the decline, societal drift downward that we have after TBI, what people lose as far as structure, family, marital things, job, what happens as these things fall away. But there are really so many fewer after compared to the spikes ahead. And there is, I think, a fairly big spike right before the person become homeless. But the time lag is important to me because we're going to keep coming back to the age of the people who had the TBI. Next slide. And this is from the Wilder research people again. And you can see they had a little lower incidence of homelessness or injury before homelessness. And whether that was from being urban, rural, or whatever, I don't really know the answer to that. Somewhere I wrote down what they found in their 2018 schedule survey, but I think it's probably disappeared into my forgotten file here, so I will not be able to tell you that. But it's very interesting. You may want to go and look at that recent survey. And the next one, once again, talks about the age of when the people sustain injury. And once again, it's mainly mild. Wang used as a discriminating thing between mild and moderate or severe was the person unconscious for more than a half hour. So anybody less than a half hour being unconscious was mild, and then moderate and severe were lumped together. Next. And so what happens when you have become homeless at a younger age? More years of homelessness, more seizures, more mental health problems, alcohol problems, drug problems. And if you just think about the kind of issues as far as impulse control, judgment, I have to say that I didn't become alcoholic, but I certainly felt an allure of alcohol with my brain injury, partly because I would run out of me before I ran out of the day. Plus the alcohol was kind of helpful in treating the pain, also the sense of loss and the sense of purposelessness, and how to fill unstructured time. Most of us think it's nice to go on a vacation. Some people, I said, gee, aren't you happy to be retired early? And I thought, involuntary retirement is not the same as voluntary retirement. If you can't do the things that you would like to do, in my case, I couldn't read for very long. I couldn't watch television. I grew up in Kansas and was a big basketball fan, but I finally learned that, if I watched basketball or if I watched TV, that made my headaches worse. It was a big cognitive drain. But you're all of a sudden stuck with a lot of time that you don't know how to fill or don't know how to fill productively. And I think that has something to do with the substance abuse problems as well as the mental health problems. Next. And as I mentioned earlier, it's a signature injury of the wars in Iraq and the Middle East and Afghanistan. But most of the people who have TBIs in the military are not combat related. This data is from John Corrigan, but once again, this high associations with the same, with the other problems. I think of professionals who work in the area of substance abuse, mental health, and also in the area of homelessness need to really think about traumatic brain injury and ideally need to screen for traumatic brain injury. The next slide shows what happens to the veterans who have a traumatic brain injury. And they're 2 or 3 times more likely to become homeless. And there's a National Association for Homeless Veterans, and they endorse something I'll talk about later on, which is called CogSmart, which is a program that teaches compensatory strategies. I'm racing through this faster than I thought I would. I'm going to turn to TBI in prisons and jails. This is something I really didn't know very much about, actually, before this talk. There are about 600,000 people who are released from prisons and jails each year. already talked about how prevalent TBI was in the penal system. But I learned in reading that, people who were formerly incarcerated are about 10 times more likely to become homeless than the general population. And if you've been incarcerated just once, your likelihood of risk of homelessness is about 7 times as often as the general population. But if you've been incarcerated more than one time, it jumps to 13 times as much. And one of the problems in at least many areas is if you're homeless, you're likely to be incarcerated for other things. It ends up being more and more of a revolving door. You get arrested for loitering or sleeping in a park or on the street. You go to jail, you don't have money to pay the bond. You don't have a permanent address, you can't get a job. Many communities have discrimination against people who've been incarcerated. The federal government just says there are 2 categories of people that you can discriminate against: those who are sex offenders and those who have made meth. Since I said there's not a lot of research on this as far as how many of these people really have brain injury, but I think at least in my mind, when I look at the percentage of people in prisons who have brain injury and the percentage of people who are homeless who have brain injuries, my feeling is there's got to be a lot of overlap there. Then we come on to domestic abuse and intimate partner violence. And where do people usually get hit? They usually get hit on the head, face or neck. And that's from an older study. And then how many women usually lose consciousness when they've been abused? And 2/3 of them report residual problems. One of the things that's happened in our local effort is when the staff at the domestic abuse shelters have used the OSU screening tool, they report we're able to get a much more complete history of the person's abuse. And they use it in a way where it's not like they have to do it all at once. They stop and stay with the woman wherever she's going with her emotional issues. So it's not like a cookie cutter kind of thing, but they said so often the women will try and minimize what happened or not really allow themselves to be fully aware. But that was interesting to me. The next one is a different kind of study of how often people are hit in the head and how often they're battered. I gave a talk a number of years ago to a joint session of the Child Protective Placement Unit of our county and the Domestic Abuse Center. And I asked the question, if you have one person who's suffered a traumatic brain injury, do you think about screening the other members of the family? They said, no, we had never thought of that. But I think that's a useful thing to consider. The other thing I think is, do you teach the mother or do you teach somebody in the family how traumatic brain injury looks different in children? How you can't really see a deficit till the skill is supposed to happen. And it's like we have different expectations of somebody who is 7 and somebody who is 17. But if you suffer a TBI early in life, you really never catch up altogether. And you frequently see that skill deficit. And I just wonder in my own mind how often there are diagnoses in children of attention deficit disorder, conduct disorder, oppositional disorder, anxiety, depression, that really may have a TBI lying behind that. But I think, children, it's easy to miss because of the obvious behavior. And like I said earlier, we diagnose what we know. The next slide talks a bit about children and TBI and how many people had pediatric admissions. and how many people were hospitalized, and then how few are in special education. And even though they have cognitive limitations, I think that problem still goes on, from at least in this area, in our geographic area is what I'm talking about. And the next slide talks about the number of people that should be in special education, and this is an older study, and the number that actually are. And also then, how many of the people in special education actually have a traumatic brain injury? Because I think frequently the interventions really need to be different. Once again, this is an older study from Wayne Gordon, but I think the statistics are really quite striking. He has done similar studies in the penal justice system. Also, if you look at juvenile offender studies, there's an extremely high rate of brain injury in juvenile offenders. Colorado has done a lot of that work, and some other people have also. Next one. And this just is following us up the age group. She did an interesting study, a large study, and once again, 51% of the people have TBI before they become homeless, and they have it before they become 15 years old. They become homeless at a younger age. They have mental health problems, more substance abuse problems. I'm kind of continue to back this up to think about, what happens if we can identify and intervene earlier. You can't get rid of all the problems, but you can, I think, mitigate some of them. And then on to the next slide. This is an old slide from the Wilder study. In 2018, they actually said, as far as substance abuse, 28% of the people said, well, I might be someone who abuses substance. But when they ask about, have you been in a treatment program, 47% said yes, they've been in an outpatient treatment program within the last 2 years. So I tend to go with a higher percentage versus the lower percentage. They also found that 76% of the people have mental illness problems and 65% chronic health problems. They didn't ask a particular question, they didn't set out separately traumatic brain injury, but they had a couple of questions that I thought really would have caused me to think, I'm back with the Whitener study still a moment, that made me think that they probably did have a head injury or brain injury. They asked, one of the questions was, have you been hit so hard that you saw the stars or were knocked unconscious? And 54% of the people in the homeless study by Widener said yes. And then 65% of those who answered yes said, I've had ongoing problems with headaches, concentration, memory, understanding, sleeping, and getting along with people. Oh, I guess I just jumped over this slide for the next one, but this just basically says kind of what we've been talking about, and it fits with the article by Burton, the interview with Wayne Gordon about the downhill course of, can we go back a couple of slides to, to this one? You can see from what we talked about, the cognitive function, the frontal lobe function, how those things really impact. There's also some nice studies, particularly in adolescence, that people are not able to read the social cues of other people. And that contributes, I think, to a lot of the erosion of relationships or the inability to build relationships. Lynn Turkstra, who used to be at Madison, had done some of that work. Now I can go on having gotten it's more challenging. I appreciate you doing the slides. I just am kind of, we switched to mental illness, and there's some other statistics that are, more precise, but I just think these are the ones that are kind of a general idea. Depression frequently follows traumatic brain injury. Certainly there's an increase in suicide risk, more of an increase when persons have TBI and substance abuse, and even more when they have substance abuse and alcohol and TBI. And once again, the childhood increases of ADHD, conduct disorder, oppositional defiant disorder. I sometimes have done informal consults with people in the school system who are struggling to get their child recognized as somebody who had a TBI. I think it's useful to go through that. Next. This really kind of outlines what we've talked about before. In the kind of chaotic recommended resources that Carly sent out to you that are evidence of my own cognitive limitations, that you could have gotten a more organized form in a week or two. But there's some very interesting work by Wayne Gordon, and I would recommend, he has 2 talks that I recommend, one on substance abuse, and one of them is called What If a TBI? One of them has more details about using the accommodations that have been developed by OSU, but I recommend both of those. Now we're going to come to the terrible trio. I had wanted to call this the terrible trifecta just because it sounded neat, but trifecta usually means something that's success or a win. And I thought, this is not a win. These were people who were seeking treatment for a combination of a dual diagnosis, mental illness and substance abuse. And they screened how many people have a TBI in that clientele. And 80%, and that's an earlier study in 2007. Later study is in 2017, same about 85%. And in that category, 25% of those had moderate to severe TBI. I think many of those people don't recognize that they've had a TBI or don't make the connection between their traumatic brain injury and the problems they're experiencing now. But I know when I first started in practice, people were really focused on the dual diagnosis. And I can look back and see some people that I clearly recognize they had a traumatic brain injury, but I can also think back of, gee, I think I missed that in this person. Partly because there was nothing in the curriculum about traumatic brain injury, either in medical school or in psychiatry at the residency program I was in. Next one. And this is a quote from Jennifer Hiley. She wrote a pamphlet, and I think this is really true. The person has learned to appear to be more highly functional than they are. And I know from my own experience that that's the case. People say, well, gee, you ought to be able to do this, or you ought to be able to do that, or you ought to be able to do this without having to stop or rest up. But I think we have social skills that we learn to use. And so next we'll look about what are the ways to think about finding the diagnosis. Well, we miss the diagnosis first. I think oftentimes a person doesn't know that they had a brain injury. And then the secondary problem gets to be the primary diagnosis. And the effects can be subtle. And I think, particularly if they're slow in onset, the family sees that they become gradually adjusted to it. And as I mentioned earlier, many professionals and families have limited knowledge of traumatic brain injury. As I said, my experience was, more than 20 years ago, but I'm kind of an informal consultant to people who fall between the cracks in Appleton. So I don't see the people who get appropriate treatment. I see the people, which is a subset, who are lost in the system or people disregard or don't make the diagnosis. So it's not a fair statistical impression, but I'm sure that people still are missed on a fairly consistent basis. Next. And so how do you identify TBI? It's important to know that if somebody says, well, your CT scan was normal or your MRI was normal, that doesn't mean you didn't have a brain injury. Those can be positive if you have structural damage, if you have bleeding, and they can be positive acutely, but they don't help at all in people who have more chronic symptoms. And having a negative scan doesn't mean you don't have a brain injury. So I think the first thing is having a high index of suspicion. Could this be there? There's no blood test. There's no simple way of doing it. The two ways I think are, neuropsychological testing, which in our area, at least in probably most areas, is expensive, and there aren't a lot of neuropsychologists to go around. And I think that's why in our project, we use the OSU TBI screening tool, and I think that's probably the best tool. There are times when helps might be appropriate, but we really chose to do the OSU study. Now I'm going to talk some about the Appleton Project. First I need to say, this is one of the things I most like about Jennifer Hiley. She has Appendix C in this little booklet that she did for the National Health Care for the Homeless. And she talks about how to frame questions and how you can ask the question in a way that doesn't lead to an automatic answer. And I recommend that as something you might want to look at. And instead of asking, why didn't you? What took place? And did you have schooling after high school? Would it be technical schooling? Could it be any number of different things? But it's really different. You're likely to get a different answer of how far did you go in school? And were there times when you were in special education? Or did you have certain problems? Same kind of thing about, do we make an assumption that people can read and write at a certain level, when in fact they can't? Now I can go on. So here's a list of different screening tools, and I'm not going to talk about those, but I'm going to refer you to a webinar done by Rebecca Quinn on May 6th, 2020 on this same Wednesday webinar series, which is a really nice webinar focused on the use of screening tools. And when I started doing TBI, the OSU wasn't really known. BISC was known, and that was one that you did by computer. You had to mail it to New York, and it cost money. So I think, and the other was at that time was RBAN. So we basically used helps, but now I think the screening tool of choice would be certainly for research kind of stuff is the OSU one. Now I'm going to move to Brain Fox Valley. This is a neat acronym: Brain Injury Recognition Accommodation Intervention Network. The Appleton Project really has two components: the Brain Fox Valley and then the grant and what comes out of the grant. The initial group of Brain had the community foundation called a group of people together who were interested in, potentially interested in brain injury, and they included homeless providers, sheltered workshops, representatives from the two major medical providers in the community, people from sheltered employment like Goodwill, early childhood outreach, children's health in our area was provided by Catalpa, domestic abuse centers, and mental health providers. Then they had a follow-up, how many people really were interested in staying in this, and they met with a consultant in focus groups for a while. And they then chose as co-chairs two really dynamic, powerful, determined women, Kathy and Diane, who are still the co-chairs of this, and an ongoing smaller Brain Fox Valley group that has looked at this project, Brain initially had two major projects. One was identifying a screening tool, which was decided on the OSU, and one was on assessing what are the resources in the community. And but the actual functioning working group of Brain Fox Valley turned out to be representatives from the County Aging and Disability Resource Center, Human Services, two major medical groups, Goodwill, NAMI, and the other people I mentioned, and four persons who had sustained a TBI. And I got to be one of those four people, so I'm going to talk about this in a much more positive way because I'm not in a position to take credit for what's been done. I just was along on the committee. And the next slide gives you an idea about how long this took. There was an initial meeting in 2014, and then they did all this committee work and stuff. And finally, they got the 5 sites committed to do this. And in August of 2016, we did an educational and training session. And we asked, this was for the staff of those 5 sites, and we asked the people beforehand, how many people that you work with do you think have a brain injury? And their guesstimate was 12%. When they started screening, they found it was 52%. And then we did this, collected all the data and stuff as so we could apply for a big grant or a grant for 3 years, which we obtained from the Community Foundation, which then led to the creation of this new entity, the Traumatic Brain Injury Program, that once again has 2 outstanding women leaders. One is not chair, anyway, one is the leader and one is the person who's in charge of navigation. And they're involved in both this project and also in community education. The next slide shows the 5 sites. And Christina Inn and Harbor House were domestic abuse centers. The warming shelter was kind of a one-night stay for people who are homeless, and where you had to sign up and come in and stand in line. Homeless Connection really provided emergency shelter for families, men and women. And the mooring program was a residential substance abuse treatment program. The warming shelter and Homeless Connection have combined and are now called Pillars. The mooring houses changed its name to Apricity. Harbor House and Christina are still operating under the same name. And then the next slide is just a visual thing about what happened. The other thing that happened with that is we did education about what they knew about brain injury, and we did education about how to use the Ohio State screening tool. Not only did they increase the pre-test on their knowledge of brain injury also increased significantly. And they came out of that training session knowing how to use the OSU screening tool, or beginning to know how to do that. And this 52% that is there probably underestimates the people who are really had a brain injury, partly because I was just so conservative, I used that number. When you look at the number of people who are dazed or confused after their event, that was 78%. And if you look at the real criteria for brain injury, that probably is the accurate number, but I've stuck with a conservative number. The next slide is just a graphic demonstration using the, this is the number that they screened at each location. The first 2 are homeless things, the next 2 are domestic abuse centers, and the last one is the mooring program. So that's how we got the 331 people in these 8 months. And the next one. So you can see the 76% there is probably a more honest, accurate number of the people who were really suffered a brain injury. And the next slide will be where I look at the graph. And so 54% had loss of consciousness. I don't have a graph for the other 76%. The next one. I want to talk about some significant changes, and some of this is going to be quoting staff members, and I think that's important because the staff actually gets pretty enthusiastic about that, and they really change how they see things and they change how they interact. The facilities themselves also make some significant changes. They change the lighting. They also change where they begin to have a quiet room where people in the substance abuse program can go and decompress afterwards or can leave the things. The substance abuse program changed its format from 3 times a week for an hour-and-a-half session to 1 hour, 4 times a week. I'm not aware in our area of any substance abuse programs that are really designed for the limitations that somebody might have with a traumatic brain injury. The amount of information they can process, the rate at which they can process that. Move on to the next. This is not just one. We have several people who said similar things. But you know, a lot of these people were ready to send away. They were non-compliant. They didn't qualify for the program. They were, you know, problematic in many ways. But they began to think about the brain injury. They begin to assess for it. And then you see on the next slide, now they look at it in a different way. And I think this change in question, what has happened to you versus what is wrong with you, is a really major different orientation. It changes to how can I help you? And it doesn't see the personal as having a choice. There's a difference between when people choose to not do something versus when they're not able to do something. And so these changes will lead to a problem we face later on. But now we can go on to the next slide. So I'm going to recommend, I'm going to tell some anecdotes, but I'm going to recommend that you watch the video I put on there of the kind of panel discussion for about 50 minutes. And the important parts are at about 12 minutes and 52 minutes, which are frontline workers telling stories about how the awareness of TBI has changed their practice. But now all sides, instead of just saying, oh, the person doesn't remember things, they have calendars, notebooks, and they really work with the person to help strengthen the skills they have, to look at ways they can do it together. And it's a cooperative effort. And like the bottom line says, we're more understanding, we're more empathetic, but there's really a skill building, collaborative effort versus feeling frustrated and, you know, why isn't this person participating like we expect them to? Next slide. And this was one of the things I like in this slide. It goes on in some other examples. The person is really educating the community as well as helping the individual. And the person can't remember the name of Christy, but she can remember that she sent her to the support group. There's an example from the Homeless Connection of somebody who was working with a client who really had difficulty in obtaining an apartment. And because she had a kind of bad record, well, the caseworker went with her to talk to the landlord and explain to him what the signs and symptoms of the brain injury were and how the person could understand that and how they could work together. And the person was then housed there, but was kind of not just teaching the people in the shelters or in the facilities, but beginning to teach the community. I'll talk about dreams later on, but the next one. Well, this is the one you should listen to at 12 minutes, because this is a story by Ron, who is the executive director, story by Jerome, who was the executive director of the Homeless Connection, and told this story often. Jerome had been in law enforcement for 26 years before he became the executive director of what was then the Homeless Connection. And he had known Ron over the years in that role. And he said, you know, we really saw him as a drunk troublemaker who used drugs, totally irresponsible. He kind of cycled in and out from unstable housing to jail and back and forth. He said when he was out in the community, it really took a lot of force from several officers to subdue him usually. And then they came to the understanding that, gee, he did have a traumatic brain injury. And it turned out he'd had a traumatic brain injury because he'd been on the goalpost trying to press the girls' track team and had fallen off and clomped his head. And then from then on, his life went downhill. But once they identified the traumatic brain injury and began to make some accommodations, he's not been incarcerated again. He has not been a troublemaker. He's been stably housed. Jerome says he still drinks, but not to the same extent. It's not a problem now. But this, I can't tell it with the enthusiasm and first line experience that Jerome has. But so that's an endorsement for looking at that video. Next. And then some other changes at the different sites. And I think they just recognize what are kind of the limitations and what kind of accommodations we make. And as you've heard already, some of the accommodations are really pretty simple, but we have to think about, does somebody have a lack of ability versus a lack of desire? And then the next slide. This is really reinforces the thing about lighting, about quiet rooms, something like that. It's easier to modify the environment than it is the person. And people still are wondering, gee, am I enabling the person? Am I doing too much? My analogy is, you know, if you take a phone call to remind somebody with a memory problem, it's no more enabling than taking a wheelchair out to a minivan for somebody who can't walk. I mean, you're addressing something that they don't have control over. I think of it as supporting, not enabling. But frequently people have been worried, less so now because I've been on this for a long time around here. So I don't hear that complaint as much anymore, at least not from people who've been working in this places very long. Next. And this is really just something you probably do already, but you know, asking a person, because what's worked in the past, how did it work, what hasn't, you really are forming a partnership with the person and figuring out how do we want to do, and we are not going to repeat the things that don't work. We're not going to spend a lot of energy doing something that's not going to work. And the next one, the person really is the expert. They may have expertise and knowledge, but they don't have any idea because they've not looked at it as a problem. They've just looked at it as part of them. I think of somebody I did a consult, informal educational consult at Harbor House, who had always been taught by her family she was dumb and stupid. She couldn't do these things. And as we were talking, I talked to some about the symptoms I had. She just broke down in tears and she said, you know, that's really what I've been struggling with. And also some of the other workers have talked about the person getting rid of a sense of shame or a sense of embarrassment and seeing that, you know, this is not something innate, that is just who I am. There's some things that I can do that can be compensatory for the things that are not in my skills to do. And then the next one, I want to talk a little bit about the present situation. So what's the one of the major problems is staff turnover. So Julie and Harper from the Traumatic Brain Injury Support Program have really started doing ongoing educational efforts at the sites as well as education in the community. And Harper has become a brain injury certified specialist, and Julie is in the process of doing that, and they've used the brain injury 101 and OSU identification method. And in the future, we really plan to add the skill builder thing from CBIRT and CogSmart, which is a kind of cognitive rehabilitation program that was designed by Twomley for veterans. And so I think of this as an ongoing thing because there's going to be staff turnover. People are going to get busy. They don't want to do it. One way of demands on staff time, the OSU screening test for pillars, the homeless connection, and the warming shelter, much more done in the homeless connection because the people are there for a longer time and it can be done not all at one sitting and they have more staff. But the OSU is part of the intake thing. And so almost everybody gets screened. It doesn't happen all at once necessarily in the first, visit, but people are committed to doing that. And so the demands on staff time is a real issue. And I think the thing that helps with that is that they get to see the benefit of knowing what's going on as far as effective treatment, also more job satisfaction. But it's going to always be a real problem. And the next slide is something I really believe in, and I'm kind of a semi-evangelist salesperson for this kind of thing. And I'd ask you, if you know of something like this going on in your community or anyplace else, please let me know, because I'm interested in learning from other people. But I really think that you can recognize the limitations and you can teach your clients strategies that will make the therapy more effective, your interventions more effective, and improve the quality of their lives. And as a result, improve the quality of the people who care about them and society as in general. So I'm going to say thank you and then ask if you have some questions or comments that you'd like to make.
If you have questions, you can either turn your microphone on and ask with your voice, or you can type in the chat box. Tom, one thing I kind of thought of, what's your opinion on, so the shelter here in Grand Forks, they're not allowed to have alcohol, but the one in Fargo, they are. Do you have a opinion on that? Or you think it should be allowed, not allowed?
I don't know.
Not allowed?
I don't know is what I'm going to say.
Okay. I don't know. Just curious what your thoughts were on that. Yeah.
I don't work in that environment. I just kind of a consultant from a distance.
Sure, sure.
I think it depends on, depends on what the goal is and how, in Wisconsin, I grew up in Kansas. And so my definition of how much do you have to drink is really different when I moved to Wisconsin.
Sure.
Carly, can you hear me?
Yep, go ahead, DJ.
Feel like someone else was trying to jump in too. Sorry if I cut you off. So is a majority of the people who are here homeless service providers getting educated about this, or I'm seeing an awful lot of people, and that's great. But I was just kind of wondering, is it, are some people who are here homeless service providers in North Dakota?
Hey, this is Ruth Buffalo. I do a lot of anti-human trafficking work and advocacy across all communities in North Dakota, but and then have close family, immediate members who have traumatic brain injuries. And so I know the prevalence is pretty high in American Indian communities, and I know that a lot of people are undiagnosed too. So thank you for this presentation, and I shared it with my family members and community, but just wanting to learn more and hoping that that we can provide services or find services to connect people who need it the most, especially in rural communities, because I appreciated the presentation because it really is spot on to what we're observing with immediate family members. And there's a huge need, I think, in Indian country for more awareness and resources. So thank you.
If you go, can I speak?
Yep.
Okay, if you go to the Widener Research Group, they have a specific section on Native American and traumatic brain injury. You might find that very useful. I see that there were several questions about CEUs, and I would lead me to endorse the kind of training programs from Ohio State University on training for identification, training for accommodations. You can watch those for free, and if you pay $20, you can get CEUs for it.
The reason I was asking about that, Tom, is because I actually, I'm a survivor of traumatic brain injury, and I was homeless for a short episode myself. And I ended up working for the North Dakota Coalition for Homeless People. It was a coalition of homeless providers here in the state. And I know that they do, I mean, I'm not with them anymore, and I don't remember exactly, but to what extent like their SPDAT training went into screening for brain injury prevalence among their populations. But I can see this being an enormous opportunity for our homeless service providers. I just am not seeing any names that I recognize. And so that's where that question came from.
Okay.
So we did have a few respond. Some said they are VR counselors and assessment specialists. We have, and a lot of people, you know, with family members with TBIs. We have people from North Dakota Brain Injury Support Group leader. We have someone from the Brain Injury Alliance of Washington. So kind of all over, DJ. So, yeah.
Yeah, so boy, I just wish that this had, you know, maybe there's an opportunity in the future for us to invite Tom back for another panel discussion, and we can bring in the homeless service providers here in North Dakota.
Mm-hmm.
I've got connections to a lot of the, you know, EDs and stuff from my work with the coalition. So
Good.
really good job, Tom.
Rebecca we're possibly doing some things with CVIC, which is one of our domestic violence shelters here in Grand Forks, some trainings with their staff as well.
Right.
Upcoming, so that's really good too. But yes, Tom had great information.
I said earlier, you know, I give free talks to people I think who need to know about this stuff. So I'd be happy to try and arrange a time to do that sometime, especially now that I don't have to travel.
Yeah.
Yeah, right.
That's happy.
That'd be great, Tom. Thank you so much for the information. It was really, really, really good. Really good.
I think if you really go through that disorganized recommended resource thing, there are really some things that are practical that will help people in clinical situations, as well as some of the more research-oriented stuff.
And then we have someone's hand raised. JP, are you there? You want to ask your question?
Yes. Can you hear me?
Yes, we can.
Okay. Well, I did pull a little stint as a correctional officer for a while after I got out of the Air Force. My question is, do you folks offer classes or instructional manuals for both correctional officers and police officers as to what to expect, what to look for, and how to handle situations? And the reason I ask that is, again, when I was performing that duty, nothing like that was available.
Actually, I do have some resources that are not listed there that I'll have to try and look up, but there are some specific things that are written by the CTC for correctional and justice system employees, but there are also some practical, what do you do kind of things. And I think of it, I would like to see, I'm part of NAMI. In Wisconsin, we started doing CIT, which is a training program on mental illness. And I would love to see traumatic brain injury have the same kind of thing. If you can send Carly your email address or whatever, she could send it to me and I'll see if I can find that stuff and email it to you.
Okay, to follow up on the question also, has that ever been, my particular question, has that ever been addressed by our judicial, or actually our government, basically, the governor, Senate, and so on and so forth? Do you know if that's ever been addressed? Have I lost you?
I'm not in your state, so I don't know.
Oh,
Yeah, Rebecca, can you speak on that more than I can? I'm not sure.
well, you can always get back to me later.
Okay, we will.
All right, come on, thank you.
I do know where we got our modules from in North Carolina. We have some online courses that we offer through the Brain Injury Network, but we did get them from North Carolina, and they have a good one that's for first responders. And if someone were to have, you know, an older TBI and come upon like an accident or something, and how to handle that situation. And I have done that presentation for some of the first responders here in Grand Forks anyways. And we talked about possibly making our own module, but it's very, North Carolina's is very North Carolina specific, so we need to adjust it to North Dakota, but we have talked about that.
And again, the reason I'm even bringing it up is when police officers and correctional officers meet folks or interact with them, it's not usually in the best situation. So anyways,
Right.
thank you.
Yeah.
There are also some videos from Canada about how to interact with people who have brain injury, and also a set of videos of what the person with a brain injury should do. I'll try and find those and send them to Carly.
Thank you, Tom. Thank you.
Thank you.
Hi, Kylie. Go ahead. Yep.
Hi. So yeah, I'm a resource manager for Brain Injury Alliance of Washington. So from Washington. And then I'm also a member of the TBI Council under our governor here. My question, I really appreciate these webinars and I love that they're every Wednesday. I was really tuned in today because one of my clients, participants, survivors, is currently homeless, and at least in our state, trying to access services during this particular time. I'm sure many people can speak to the fact that, you know, it's difficult navigating the system anytime, but you throw in a pandemic and it just becomes almost impossible. I just wondered if anyone could speak to, I see there being a lot of push and effort to adapt and change in certain systems. You know, take school, for example. I feel like a lot of colleges are changing, even public schools are trying to change. And my hope is that through all this suffering and difficulty and challenging times with the pandemic, that we'll see more opportunity for growth and change, especially when it comes to our homeless populations, neighbors, friends, families. And I know it's obviously different state to state. So North Dakota probably looks different. But yeah, I just, you know, trying to connect my client with any type of service right now as a homeless citizen has been almost impossible. What do you think can be done to shed light on some of these these disparities during the pandemic, but make sure that we take this moving forward as a way to impact change.
Tom, that's for you.
The honest answer is I don't know, but I will try and send you, I think it's from Texas. I got some stuff on homeless and prisons, and one of the articles said, you know, investing $1 in homeless care saves $13 in other places. And I don't know about your legislature, but our legislature listens to that kind of thing. And I think you might want to talk to people in Colorado, and you might want to talk to people in Iowa, who are very good at making the kind of economic argument. Our state used to be on the Brain Injury Advisory Council, and then we had a governor, and all that went away. I think we're the only state that doesn't belong to NASHA. In fact, I know we are, or doesn't have a real connection. But no, I don't really have an answer to your question, and I think I'll stop there because I don't know.
But I think what you're doing by educating just the staff alone is shedding a lot of light, Tom, wouldn't you say? And you know, changing the stats by doing screenings. I love that you're doing intake screenings. That's great.
I started to say what my dream is ultimately is to have this, like, money follows the patient. You get this education into the, particularly the county mental health providers, that you begin to educate more substance abuse providers, and a lot of communities have become dementia-friendly communities. I would like to see a similar kind of thing happen for this invisible kind of thing, because people frequently say, well, you know, I should just try harder. Well, you know, I had a lot, couldn't get adequate treatment here. And one of the people, anyway, I'm not going to get into that, but it was not satisfactory. But I think trying to treat people and just, I invite myself to Rotary clubs, to church outreach things. I think, I don't know the answer, but I think trying to get people, not just providers, but trying to get other organizations that might have leverage or concern. That's where I think of, we have something here called Noon Hour Philosophers, and I've done that several times, and it's just a group that includes, well, as I get older, my definition of older moves a lot higher into the future, but a lot of people who are mature. So I don't have more to add than that.
Tom, we did have someone ask if you're okay with us sharing your personal information, like how to get a hold of you, your contact info.
I think so. I have to warn you that my own brain injury has limitations as far as cognitive energy and response, but yeah, I'll try and respond.
Okay. I will get it to her then.
The difference between the funneling it through you and funneling it directly to me.
Yes. And then, was it Dr. Harvey and Kayla? Did you guys want to talk about your stuff in the chat box at all? Someone had asked if we have designated persons in North Dakota to case manage homeless people, and then Kayla had responded. Do you want to talk a little more about that at all?
This is Denise. I'm not a doctor. Sorry, it's just my initial.
Sorry, so I never know.
Yeah. Okay. Do they used to have homeless case managers at the Human Service Centers, and they don't anymore. So if someone is homeless, how would that be addressed? I mean, I know it says there's case managers. So do they assist people with homelessness issues?
Kayla, are you there? Do you want to talk about that? Or Rebecca might know too.
I mean, I know they have in the past too. I'm just kind of checking now with the changes.
I don't know. I can't say for sure, but I would think they would.
They used to have designated homeless case managers, I know.
Okay. Yeah. sorry. We can follow up with you though. I can look into it for sure.
Okay. And are there homeless coalitions in every region?
And so Tom is in Wisconsin.
Mm-hmm.
So
Okay.
do you have?
I'm maybe just thinking more in general in the human service center areas, that type of thing, or in regional areas, Northwest, eastern part of the state, whatever.
I couldn't say, but I can look into it.
Okay.
When preparing for this, I ended up looking at the PATH program for North Dakota.
Mm-hmm.
Was the budget funding thing, so I don't know what part of it is really real, but they had case managers by region. And I don't know whether that exists in reality, but that might be a place to start to look.
Mm-hmm. Okay, thank you.
Yes, and I'll follow up too with you, Denise. I'll do some.
All right, thank you very much.
Stepped away, but she probably knows. But yeah.
Sure.
Oh, Kayla doesn't have a microphone. I guess I didn't know that. And then someone else is saying yes, there are still PATH and homeless case managers at each human service center. So they must not have got rid of them, Denise. Or must have brought them back. They did get rid of them. Kylie in Washington talked about our state has 2. West Seattle and East, everything else. The East side is really lacking in providing supports and services across the board.
Yeah, we were told they don't all have homeless. I mean, there was one I know that didn't have a homeless case manager. So
okay.
Anyway, but that's good to know. We can check about PATH too. So
yeah.
Thank you, Michelle.
Okay.
Yes, we looked at the West Central right now just because she took a different job in another agency and we're hiring another one.
Oh yeah, I don't know of it being West Central, but just a different area. So, okay, thank you.
Anyone else have any questions? I'm just gonna put Tom's email address for you guys in the chat box. So if anybody wants to email him later, or you can always email me and I can reach out to him as well. Thank you so much for your time, Tom. I thought that was great. Really good information.
Couple of them.
It's nice to hear that the accommodations don't have to be so elaborate, you know.
Can I give a couple of endorsements in the recommended resourcing?
Sure.
I think the same thing from CPRT as far as, I don't remember the exact title, but it's training frontline staff. It's a multiple module unit that is really directed for service providers and has good examples. There are videos and you can take a little quiz and stuff, but it has good examples of how to do things and not do things. And the OSU things I highly recommend as far as easy and useful kinds of things, either for you or for people that you want to teach about accommodations and screening. There may be some others that I just don't remember at that time. And once again, since I'm not one of the people on the performance, I really am deeply moved by the video that it was actually, the Women's Forum has speakers and then they have an issues forum for that. And Ann McKee was from Appleton, so they brought her back to speak, and they had to find something that had to do with brain injuries before that. But it gives you, I think, an experiential feel for how the staff feels better when they're doing this kind of work. I really appreciate the opportunity to talk with you all, and if people know similar things going on, let me know, or if you have suggestions, please. I'm interested in learning from you all as well.
Yeah. Okay. Well, anyone have anything else, or are we good? Yeah.
Thank you, Tom.
Thank you. Yeah. Thank you very much, Tom.
Thank
DJ, are we doing our call?
Actually, no, Carly. Let me get a hold